these are the relevant financial disclosures for this activity. I'm excited to introduce you to our speaker, a colleague, collaborator, and a dear friend of mine, Dr. Somsekhar Krishna. He is advanced endoscopist and director of clinical research, currently appointed as associate professor of medicine at the Ohio State University Wexner Medical Center. His key area of interest is advanced endoscopy, but specifically, he works in the field of pancreatic cystic lesions, acute pancreatitis, application of artificial intelligence in endoscopy, and luminal stenting. The topic for the day is an update on accurate diagnosis of pancreatic cystic lesions. I'll hand the presentation over to Dr. Krishna now.
Thank you for the kind introduction. And also thank the American College of Gastroenterology for giving me an opportunity to present this talk on pancreatic cystic lesions. So pancreatic cystic lesions are extremely common. Nearly 8% of cross-sectional imaging studies, that's either CT or MRI, performed in asymptomatic patients can detect incidental pancreatic cystic lesions. If you just look at MRIs, nearly 1/4 of any MRI done on the abdomen can identify incidental cysts in the pancreas. There is also data showing that this incidental prevalence has been increasing year by year. And why is it important? Now, if you look at pancreatic adenocarcinoma as a whole, nearly 20% of cancers can arise as pancreatic cystic lesions. The remaining 80% choosing the other common pathway, which is called the Panning pathway for pancreatic ductal adenocarcinoma. So pancreatic cysts are broadly classified into mucinous and non-mucinous cysts. The mucinous cysts include IPMN, which is intraductal papillary mucinous neoplasm, and mucinous cystic neoplasm. The non-mucinous cysts, which is all the other cysts, includes cystic neuroendocrine tumor, solid pseudopapillary neoplasm, serous cystadenoma, and pseudocysts. The other rare type of cysts, which are lined by squamous epithelium, include epidermoid cysts and lymphoepithelial cysts. Now, mucinous cysts, which includes IPMNs and mucinous cystic neoplasms, among which IPMNs are predominantly more prevalent or more common. In fact, the most common neoplastic cysts seen in practice. These are of two types, which is the main duct and the branch duct. So also there's a third type, which is the mixed type, which involves both the main duct and the branch duct. These progress to adenocarcinoma through a dysplasia pathway, which is low-grade to high-grade dysplasia, eventually reaching adenocarcinoma. These are of equal incidence in men and women, commonly seen from 60 years onwards. 70% of these are in the head of the pancreas. And among all the cysts, these tend to be the most common cysts for being multifocal. In comparison, mucinous cystic neoplasms are rare. They're predominantly seen in women and also predominantly seen in the body and tail of the pancreas at a slightly younger age, about 40 to 50 years of age. And one key issue is that mucinous cystic neoplasms are associated with chronic inflammation and consequently areas of atrophic changes. Evidence points towards at least 30 to 40% of these cysts having atrophic changes, which kind of poses a problem in diagnosing these cysts accurately. Among the non-mucinous cysts, the two cyst types which do have a malignant potential include cystic neuroendocrine tumor and solid pseudopapillary neoplasm. Cystic neuroendocrine tumors have an equal incidence between men and women. These are mainly because of cystic degeneration. They tend to have a prominent wall and prominent vascularity on imaging studies, and they're diagnosed by EUS fine needle aspiration, typically with immunostaining. And resection is recommended if the cysts are functional or if the size is more than 2 centimeters. On the other hand, solid pseudopapillary neoplasms have this classic mixed solid cystic appearance seen at a much younger age, and another cyst which is exclusively seen in women. And here as well, resection is indicated once they're diagnosed by EUS FNA. The next two types of non-mucinous cysts include serous-cystadenoma. This is a benign neoplastic cyst with the risk of malignancy being less than 1%, in fact, less than 0.5% to be precise. They're a little more common in women than men, again, seen between 50 to 60 years of age, equal distribution in the pancreas. CT scans may describe the stellate scar, commonly used as a board question. And EUS, we can typically see this microcystic appearance. Uncommonly, though, they could be macrocystic or rarely a unilocular cyst. Pseudocysts are post-inflammatory following pancreatitis. They're benign in nature. They lack a true wall, but these do cause problems in diagnosis if the patient doesn't have a clear recollection of prior history of pancreatitis, or just that the patient didn't go to a hospital, they had this acute abdomen pain, they probably had pancreatitis and result in pseudocysts, and later on in life, incidentally, imaging studies pick up a cyst in the pancreas. Now, the standard diagnostic evaluation of pancreatic cysts includes cross-sectional imaging, either CT or MRI. MRI is preferred because of higher resolution. Subsequently, EUS with the description of the morphology of the cyst during EUS, with or without inclusion of fine needle aspiration. And when you do aspiration, you get cyst fluid. Sending the cyst fluid for CEA, pointing towards a value of more than 192, diagnosis a mucinous cyst with an accuracy of 65 to 70%. Cytology of the cyst fluid has an accuracy of 50 to 60% by detecting mucin, again, diagnosing mucinous cysts. And if you combine CEA and cytology, you optimize the diagnostic evaluation, reaching at most a maximum of 75% in diagnosing or differentiating mucinous from non-mucinous cysts. Overall, this is suboptimal in differentiating mucinous versus non-mucinous cysts. In this current day and age, an accuracy of less than 80% needs to improve. Now, that's the first step in working up pancreatic cysts. IPMNs being the most common prevalent neoplastic cysts. These diagnostic techniques are suboptimal in accurately classifying IPMNs as those with low or high-grade dysplasia. And we will again discuss this more in detail. We'll now discuss three challenging cases. Of course, these are handpicked. Here is one patient with a 65-year-old man with a cyst in the head of the pancreas. The cyst measures 4.5 centimeters. It has a low CEA of 5. Amylase also being low at 50. And cytology did not show mucin. So that's one example. Just going by what we call a standard of care diagnostics, you would label this as a non-mucinous cyst. You would say, could it be a pseudocyst, but the amylase is low? Could it be a serous-cystadenoma, but it's unilocular? It doesn't have the specific morphology of a serous-cystadenoma. So we'll come back to these cases later on. Here is another example, a 50-year-old lady, again, EUS image, showing a 3.2 centimeter cyst. The cyst has doubled in size over 3 years. It's unilocular. It's got focal wall thickness, and no communication with the pancreatic duct, and no clear history of pancreatitis. And CEA is elevated at 845. Amylase is 6,000. And cytology shows mucin. So going by diagnostic standards, you would label this as a mucinous cyst, and we will visit this case later on. And the last example is a 37-year-old man who has a 6 centimeter cyst in the tail of the pancreas with no history of pancreatitis. And CEA is low at 10, and amylase is elevated at 65,000. And cytology did not show mucin. So we cannot diagnose the specific cyst type given by the standard of care diagnostics. And these are all cysts more than 3 centimeters in size. So we will visit this cyst later on using novel diagnostics. Because of these challenges in reaching an optimal diagnosis in evaluating pancreatic cystic lesions, there have been various guidelines through the last 10 to 15 years. More commonly, most endosonographers follow the International Consensus Guidelines revised in 2017, which includes a dilated duct, which is more than 1 centimeter. These are high-risk features, or an obstructed bile duct, or a solid enhancing nodule, which measures more than 5 millimeters. So these are high-risk features, and there are multiple worrisome features, which include a dilated duct of 5 to 9 millimeters, that's less than a centimeter, history of acute pancreatitis, presence of a nodule, which is less than 5 millimeters or non-enhancing on MRI, change in the caliber of the pancreatic duct, enhancing cyst wall, or a cyst size more than 3 centimeters. In addition, 3 new variables which were added in 2017 include presence of lymphadenopathy, an elevated CA19-9, or a cyst growth of more than 5 millimeters every 2 years. Now, these guidelines are helpful in risk stratification of these cystic lesions. Now, you have a patient with pancreatic cyst, you do standard of care imaging, you apply these guidelines, and you're trying to figure out what to do with the cystic lesion. Now, cyst fluid glucose has reemerged as a very potential and strong marker in differentiating cysts into mucinous versus non-mucinous lesions. In this recent meta-analysis, which includes 7 studies with nearly 600 patients, looking at a glucose cutoff of less than 50 milligrams per deciliter, that is the lower glucose implying a mucinous cyst, showed a pooled sensitivity of 90% and a specificity of 85%. In fact, 4 of these studies included point-of-care testing with a glucometer. So glucose can accurately differentiate cysts into mucinous versus non-mucinous, and the cost of the test is economical compared to using more advanced diagnostics. So I would say if you add glucose to current standard of care, you can theoretically bump the accuracy to 90% in differentiating mucinous and non-mucinous cysts. Still, there is the problem of risk stratification of IPMNs. You still have to work on improving the accuracy of differentiating IPMNs. Why is it important to differentiate IPMNs? So here is the key issue with IPMNs. Nearly 40 to 50% of IPMNs resected at large tertiary care hospitals in the US have low-grade dysplasia. Of course, there are multiple variables. You know, all the hospitals have tumor board meetings and they come to a decision as to when we have to resect the pancreatic cyst. But this is data in the last 10 to 15 years. Still, to date, 40% to 50% of IPMNs resected have low-grade dysplasia. That's one end of the spectrum. At the other end of the spectrum, with suboptimal diagnostics, you could potentially miss a lesion that would otherwise progress to adenocarcinoma. And pancreatic surgery is not a simple surgery. In this pooled analysis from the American Gastroenterology Association Technical Review, the overall rate of mortality with pancreatic surgery is about 2%, and morbidity is about 30%. Now, if you specifically look at resecting low-grade dysplasia IPMNs or IPMNs with low-grade dysplasia, in this cohort of patients from UCSF and MD Anderson Cancer Center, nearly 50% of the IPMNs resected had low-grade dysplasia. And amongst these, half of them had surgical complications and 1/4 of them developed diabetes. So, kind of driving home the point, while it's important to differentiate cysts into mucinous and non-mucinous, it's also important to risk stratify IPMNs to prevent unwarranted, unnecessary pancreatic surgery. So how do we effectively classify cysts as low risk and high risk? Of course, there are various guidelines which are helping you. The AGA guidelines, and the recent ACG guidelines, so also the International Consensus guidelines. We cannot have one universal guideline. Sometimes we just have to review most of these guidelines to come up with estimating the risk. So if you think a cyst is of low risk, you can, in these low-risk cysts, since they're increasingly prevalent, you're focused on cost-effective surveillance strategies. Perhaps you can just do imaging study, or you might consider just US with or without FNA. And if you're forced to, you might want to send for cyst fluid CEA and glucose, and then triage the patient into long-term surveillance versus not. So in these low-risk cysts, cost-effective strategies win over increasing cost of novel diagnostics. But if you have a high-risk lesion, again, to stress that IPMNs will be the most common neoplastic lesions in clinical practice. So you have a cyst with increasing size. Here, novel diagnostics do make a difference. One is, if it's an IPMN, not only to differentiate the degree of dysplasia, and perhaps in some cysts, to nail the diagnosis down to the specific cyst type, so that in some patients, we can stop surveillance. So this leads to kind of the second half of the talk, which is discussing these novel diagnostic tests. The three more common novel diagnostic tests include cyst fluid molecular analysis, EUS-guided needle-based confocal laser endomicroscopy, and EUS-guided through-the-needle biopsy using a novel microforceps biopsy. So cyst fluid molecular analysis uses a standard 22-gauge needle. It's the typical way you would obtain fluid for CEA or cytology. The fluid is analyzed typically by genomic pathology lab, either academic centers or at commercial labs. And IPMNs show mutations in KRAS or GNAS. Mucinous cystic neoplasms show mutations in KRAS only. If you just get KRAS mutations, it could be either IPMN or mucinous cystic neoplasms. And serocystadenomas show mutations in VHL, and solid pseudopapillary neoplasms show mutation in CTNNB1. Now, there is evidence showing to a collection of a few mutations which point towards a IPMN or a mucinous cyst with advanced neoplasia. When I say advanced neoplasia, it's the presence of high-grade dysplasia or adenocarcinoma. And these mutations are listed here. It includes TP53, PIK3CA, PTEN, APC, SMAD4, or CDKN2A. So overall, how do these perform? Again, it's another recent meta-analysis looking at cyst fluid molecular analysis. When you look at diagnosing any mucinous cyst, either IPMN or mucinous cystic neoplasm, using a combination of KRAS or GNAS, the sensitivity is 80% and the specificity is nearly 100%. If you just look at IPMNs, the sensitivity is higher at 96%. The reason being that the mucinous cystic neoplasms are a little challenging because, as I mentioned earlier, these mucinous cystic neoplasms have areas of atrophic changes. And to get free DNA, you're dependent on the cell death and the cell to be lysed and the free DNA to be released. So if you have wide areas of atrophic changes, you don't have that much free DNA floating around for a diagnosis. So hence, MCNs or mucinous cystic neoplasms do pose a diagnostic challenge. And here in this single center study from UPMC, which looked at IPMNs and detection of advanced neoplasia, which is presence of high-grade dysplasia or adenocarcinoma, using a combination of KRAS or GNAS mutations with TP53, PIK3CA, or PTEN mutations, at a sensitivity of 88% and a specificity of 97% in detecting advanced neoplasia and IPMNs. Of course, these single center studies have to be reproduced in multi-center data, and we are awaiting for those results. Now, what are the challenges with cyst fluid molecular analysis? One is, this is a biospecimen. If you have to ship it out to an outside lab, typically you need to ship it out on dry ice. There are issues with insurance coverage. It's not universally available at all academic centers. Even it's not available at all commercial laboratories. And there are increased costs when you use a commercial lab to process the specimen. And as I mentioned earlier, for the risk stratification of IPMNs, there are multiple studies which are looking at molecular analysis and risk stratification of IPMNs, and we kind of wait for this real-world sensitivity data. The next novel diagnostic tool is confocal laser endomicroscopy, which is real-time endoscopy-guided in vivo microscopy. And here is the setup. You have the EUS scope, which is through the needle is advanced through either transgastric or transduodenal. You approach the cyst, and the needle is preloaded with the endomicroscopy probe. And once you are in the cyst, you advance the probe and you approximate the probe to the cyst wall, and you produce this, and then you generate this video, which is from inside of the cyst, which is in real time. Here in this example, you see this patient with IPMN with multiple papillary structures. You can later review the video and pause it whichever points you want and make a diagnosis. You can make a diagnosis in real time, or you can get the optimal video and then review the case later on to come to a diagnosis. So endomicroscopy has key diagnostic features on imaging, and for mucinous cysts, you either visualize epithelial bands or papillary structures as shown in these pictures. For diagnosing either cystic neuroendocrine tumors or solid pseudopapillary neoplasms, the classic description is what's called as a trabecular network pattern, which is clusters or groups of cells, which is separated by the stroma of the cyst. A cystic neuroendocrine tumor and solid pseudopapillary neoplasm, they cannot be differentiated just based on endomicroscopy and need EUS with FNA. The next cyst type, which is serous cystadenoma, it doesn't have a typical epithelial pattern, but has a very characteristic vascular pattern, which is described as the Fern pattern of vascularity, or the superficial vascular network, where you see multiple blood vessels, and then they have this characteristic pattern, which is like a fern leaf pattern, and you might see RBCs running through the blood vessels in real time. And finally, pseudocysts, which lack a true wall, because we give fluorescein during EUS for endomicroscopy, the fluorescein binds to the albumin and travels to the blood vessels, kind of providing that light inside the cyst. Since the pseudocysts lack a true wall, they appear very dark, and there is some autofluorescent cells. Typically, these are large inflammatory cells which have some autofluorescence, and hence it looks like a dark sky with bright stars, and that's classic for a pseudocyst. So using endomicroscopy, the initial studies had a lower sensitivity because at that time we didn't know how mucinous cystic neoplasms would look like on endomicroscopy. And after the patterns of mucinous cystic neoplasms were discovered, there is increased accuracy as per two recent studies. That's the multi-center study from France and our single center study from the Ohio State University, showing a higher sensitivity of 95 to 98% and higher specificity as well. So again, this is another meta-analysis showing the utility of endomicroscopy in differentiating cysts as mucinous versus not. In this meta-analysis, they looked at 7 studies with nearly 325 patients. Overall sensitivity was 85%, specificity was nearly 100%, similar to using KRAS or GNAS mutations from cyst fluid. Now, we will talk specifically about IPMNs and the role of endomicroscopy. Now, this is a typical papillary structure seen in IPMN. It has the outer epithelium, which lines the inner vascular core, and the vascular core is bright because of the fluorescein which is given to the patients. These papillae can be seen in various configurations during endomicroscopy. They could be overlapping. You could sometimes see a large papillary structure. And you can actually differentiate the degree of dysplasia based on endomicroscopy imaging. And these are 4 patients, all with surgical histopathology, who had endomicroscopy performed prior to surgery. In the top panel, you see these 2 examples with low-grade dysplasia. You have a thin layer of single layer of cells, as seen here. And endomicroscopy reveals a very thin epithelium, which is almost translucent. And in fact, the papillary structure is not pronounced. Compared to that, when you look at the bottom panel, here are 2 examples with 2 cases with high-grade dysplasia. You have cellular and nuclear stratification. You see the nuclei traveling to the surface epithelium. And this is represented here in the preoperative endomicroscopy done during EUS, where the epithelium looks much thicker and darker. And the darkness is because the nuclei are seen as dark structures during endomicroscopy, and hence these appear much darker, as seen in these two examples. So here are more examples differentiating high and low-grade dysplasia in IPMNs. On the left, you have much thinner papillae. The epithelium is more translucent or kind of lighter in shade. And here you have much larger papillae with a much thicker epithelium. And here in this example, there are two extreme examples. On the left, you have IPMN with low-grade dysplasia with very small, thin papillae with a thin epithelium. Whereas here at this other extreme, you have an IPMN just progressed to adenocarcinoma. The papillary borders are irregular, and the papillae have a very dark epithelium because of the dense proliferation of cells and nuclei. In fact, the lamina propria is hardly seen because of this proliferation of cells. So we have initially we looked at multiple variables which could predict advanced neoplasia with either high-grade dysplasia or adenocarcinoma in IPMNs. On the left, you have resected cases of low-grade dysplasia. On the right, you have resected cases of advanced neoplasia. And we identified multiple variables: epithelial thickness, which we talked about, darkness of the epithelium, so also the increased papillary size, increased density of papillae, intricate vascularity. There is neovascularization as the dysplasia progresses. And finally, in rare cases, you may see large cells with prominent nuclei, which are basically malignant cells. So we did a study using endomicroscopy experts across the world, and they looked at 26 IPMNs with the gold standard surgical histopathology as the reference, and they were able to classify these IPMNs into low-grade and those with advanced neoplasia with a sensitivity of 88% and a specificity of 100%. And the two variables which had the highest agreement were the epithelial thickness and darkness. Now, in the same patient population, we looked at the international consensus guidelines, and the guidelines had a sensitivity of 56% and a specificity of 100% in classifying this cyst. So human observers who experts in endomicroscopy who did better than established guidelines. And in another recent publication, we looked at these endomicroscopy images have more of a homogeneous image pattern. So we have developed an artificial intelligence model because there could be significant inter-observer variation when you use human observers. So in this first iteration of the AI model, in about 35 patients with the gold standard reference, which is surgical histopathology, the sensitivity was 83% and specificity was 88% in classifying IPMNs as those with low versus high-grade dysplasia. And again, in this patient population, the current guidelines classified them with a sensitivity of 56% and a specificity of 94%. Again, here, the computer model did well compared to established guidelines, and we are working on improving these models. Of course, these computer models only get better with more cases, and we are conducting a multi-center study. Eventually, we'll be able to have more cases to improve this AI algorithm in classifying dysplasia. What are the challenges with endomicroscopy? Of course, it's not universally used. There is a need for training and achieving optimal learning curve for high quality imaging. And the entire issue with endomicroscopy is to obtain high quality pictures from the inside of the cyst. So this not only depends on the EUS technique, it also depends on interpretation to kind of go for that high yield video capture while doing the procedure. Of course, there are added costs because of the equipment, which is the processor. It can be prone to inter-observer variation, and there is a slightly escalated risk of acute pancreatitis. While the risk of pancreatitis in just a standard EUS FNA is less than 1%, here the risk of pancreatitis ranges from 1% to 3%. Although a recent pooled analysis across 7 studies showed that the risk was 1% with a confidence interval between 0 and 3. The next novel diagnostic method is using EUS microbiopsy forceps or through the needle biopsy. Again, we have to use a 19-gauge needle that is similar to endomicroscopy. Here, once the needle is in the cyst, you introduce this microforceps biopsy through the needle. You approach the wall of the cyst and you take a biopsy. And there's something called a tent sign where you biopsy the wall and then you tent it up and then you take the biopsy to optimize your diagnostic sample. There have been multiple meta-analysis. Now, there have been multiple retrospective studies and some prospective studies using through the needle biopsy. And because of these multiple studies published over the last 3 to 4 years, just in the year 2020, there have been 3 different meta-analysis using through the needle biopsy. Overall, the diagnostic yield is between 70 and 80%. And the performance of differentiating cyst into mucinous versus non-mucinous, again, is similar to using cyst fluid marker analysis or endomicroscopy. That is about a sensitivity of about 90% and specificity approaches 95%. And in one meta-analysis, they looked at the minimum number of passes where you actually take one bite or a couple of bites and come out and then go again to get another bite. So overall, a mean of 3 passes achieves optimal tissue acquisition. In this another meta-analysis where they looked at just those cases who had surgical histopathology, which is a reference standard or the gold standard. So here they had 100 patients, and the specificity for reaching a diagnosis of a specific cyst type. This is not just diagnosing cyst as mucinous versus non-mucinous. This is actually diagnosing cyst type. The specificity was about 50%. Similar differentiation of mucinous versus non-mucinous, which is sensitivity of about 85 to 90% and specificity about 95%. And in this study as well, they looked at how good the through the needle biopsies in diagnosing what's called as a high-risk lesion, where they classified high risk as mucinous cyst with advanced neoplasia, solid pseudopapillary neoplasm, and cystic neuroendocrine tumors. Here, the sensitivity was about 80%, and the specificity was nearly fully optimized. So this is a good diagnostic methodology, but there are some limitations again. There is a limited range of motion. Once you introduce the microforceps through the needle, it does make the whole apparatus fairly stiff, so you cannot really sample multiple areas in the pancreatic cyst. This does become important when you are trying to risk stratify IPMNs, because the dysplasia in IPMNs tends to be patchy. Again, there are challenges with tissue adequacy, and then the procedure has to be more standardized as to how many passes we require and where do we approach to get an optimal sample in what type of cyst. For example, if you're trying to biopsy a classic serous adenoma, which has got this microcystic appearance, how do we optimize the technique? So these need to be studied. The key limitation with this technique is the risk of adverse events. In addition to post-EUS acute pancreatitis, there is the risk of intracystic bleeding as well. The overall risk of adverse events, according to, as per 2 meta-analysis, ranges from 7 to 9%. The risk of acute pancreatitis is anywhere between 5 and 6%. So, given this kind of a brief overview of novel diagnostics, we will come back to these 3 cases which were incurred, which we diagnosed in our clinical practice. So we have this one patient, 65-year-old unilocular cyst in the head, and as you see, the CEA was low. We did do molecular analysis of the cyst fluid. There were no mutations of KRAS and GNAS, which are diagnostic of mucinous cyst otherwise. Endomicroscopy showed this images, which is characteristic of serous adenoma, so-called the Fern pattern of vascularity. As you see in this video, you see these multiple blood vessels which run parallel from another major blood vessel or bigger blood vessel, kind of what we call as a superficial vascular network. This is diagnostic of serous adenoma. Now, in the second example, which is a 50-year-old lady with a cyst which is increasing in size, no clear history of pancreatitis, high CEA, and cytology showing mucin. We did send molecular analysis, and there were no mutations, no KRAS or GNAS or VHL mutations. And endomicroscopy was actually characteristic of a pseudocyst, where you see a very dark background with bright particles. And but after multidisciplinary board meetings, decision was taken for surgery. because of the patient's anxiety, and then we really cannot, and our endomicroscopy was more in an investigative stage at that point in time, and surgical pathology revealed a pseudocyst. The last case is a 37-year-old man with a tail cyst, and here the CEA was low, but amylase was high, but there was no history of pancreatitis, and endomicroscopy showed image pattern characteristic of a mucinous cystic neoplasm, where you see these thin epithelial bands, and patient underwent surgery, and the diagnosis was mucinous cystic neoplasm as well. So novel diagnostics did help in trying to fine-tune the diagnosis and help in patient management. So putting all these novel diagnostics together, here is a table which kind of summarizes the advantages and disadvantages. So the first novel diagnostic tool is cyst-fluid molecular analysis. It's optimized for IPMN and solid pseudopapillary neoplasm. As we discussed earlier, mucinous cystic neoplasms do pose a challenge because of wide areas of atrophy or chronic inflammation. And as far as identifying VHL gene, the sensitivity needs to improve from what we see in current practice. There are lack of markers for cystic neuroendocrine tumors, but some are in investigation. And as far as differentiation of IPMNs into low and high-grade dysplasia, it's center-dependent expertise, and we need multi-center studies. The risk of acute pancreatitis is less than 1% because you just use a 22-gauge needle. The next diagnostic tool is EUS endomicroscopy. It's optimized for diagnosing IPMN. So also we get a fairly characteristic image pattern for cystic neuroendocrine tumors or solid pseudopapillary neoplasm and pseudocystadenoma as well. As we discussed, mucinous cystic neoplasms do pose a challenge because if you image a atrophic area, you don't see any classical image pattern, and they're kind of more around the cyst to struggle to get image pattern diagnostic of mucinous cystic neoplasm when we do endomicroscopy. The drawbacks are that we cannot really differentiate between cystic neuroendocrine tumor and solid pseudopapillary neoplasm, and we need FNA and immunostaining. But EUS endomicroscopy has a strong potential in differentiating risk of the level of dysplasia in IPMNs. And again, these are single-center data, and we need multi-center studies. Overall, there's a slightly increased risk of acute pancreatitis. And the last technique is EUS microbiopsy forceps. Again, it's really good for diagnosing IPMNs and also pseudocystadenoma. Again, a challenge with mucinous cystic neoplasms. And there is no data on differentiating IPMNs. And as we discussed, there is an increased risk of acute pancreatitis, and also there is an added risk of intracystic bleeding. Now, having this discussion about standard of care diagnostics and the novel diagnostics, where do we stand? So you have a patient with a pancreatic cystic lesion, and these are increasing in prevalence. Much of our pancreas clinics are now filled with patients referred for incidental pancreatic cystic lesions. Overall, they have a very low probability of malignancy if we take all pancreatic cysts. So the current guidelines should be able to help us in kind of the bottom line differentiation into low risk and high risk cysts. And if you think it's a low risk cyst, we can go for a low cost surveillance strategy, which includes imaging studies with MRI, MRCP, and EUS morphology, and if needed, EUS FNA for CEA, cytology, and more importantly, with the addition of cyst-fluid glucose. If you think this is a high-risk lesion, you might consider advanced diagnostics for further risk stratification. You might arrive at a specific cyst diagnosis, such as a pseudocystadenoma, and stop surveillance. You may incidentally find a cyst with large, thick papillary structures, which is suggestive of advanced neoplasia, or you may find a cyst with wide areas of low-grade dysplasia and say, maybe we can just survey for now. So all these, again, need multi-center data, and these need standardization. Moreover, we still need to understand how all these novel diagnostics work together to improve diagnostic accuracy. So in conclusion, a key issue we have is that there is increasing prevalence of pancreatic cystic lesions. And at the moment, we do need cost-effective surveillance strategies for effective surveillance of low-risk lesions. And there is surgical over-treatment of IPMNs, and that comes with all the associated morbidity with pancreatic surgery. So we do need technology to accurately detect advanced neoplasia in IPMNs with high accuracy so that we don't miss lesions with advanced neoplasia. And finally, we will achieve more meaningful pancreatic resections. And moreover, we need to understand the complementary role of all these diagnostic, the standard of care tests, cyst glucose, and also the novel diagnostic tests. And I'm really grateful to all the various funding opportunities we have had to do most of the studies over the last 5 to 6 years. And so also, this is our entire section of pancreatology and advanced endoscopy at the Ohio State University. Of course, each of my colleagues have been helpful in getting most of the studies underway, enrolling patients, helping with endoscopic ultrasound, and achieving these study results. Thank you.
Thank you so much, Dr. Krishna, for this wonderful talk. I have some questions which have come through, and I will field them in the order they came through. So first one is, do you use cyst glucose levels to differentiate mucinous versus non-mucinous cysts?
Yes, after recent data, we have started using cyst glucose. And again, as I discussed in my talk, we selectively use advanced diagnostic techniques. But when we don't use advanced diagnostic techniques, we do use cyst glucose with cyst fluid CEA.
Agreed. I mean, I use the same strategy. If I'm not using any advanced techniques, then I am definitely sending cyst glucose as well. And data suggests that with a threshold of 50, one can diagnose mucinous versus non-mucinous. So cyst glucose is low in mucinous and high in non-mucinous cysts. So sensitivity is about 90% or so, and specificity being around 87%. So it's helpful. Yes. Next question, which comes through, is what is your approach to workup for a 92-year-old lady in apparently good health, has multiple benign appearing cysts, which was noted on a sonogram performed for a main complaint of weight loss?
So when you have multiple cysts, the diagnosis points towards branch duct IPMNs. The other cyst type, which could be multiple, is cystic neuroendocrine tumors. But given the age group, the demographic points towards side branch IPMN. If you do have a good MRI, MRCP scan, and if the cysts are not larger in size, say if they are less than 2 centimeters, the risk of these branch duct lesions progressing to malignancy is very low. And I would, in the 92-year-old, where the chance of where the risk of surgical morbidity is so high, I would kind of keep a kind of a low risk surveillance strategy, and depending on the patient's performance status, I would risk stratify based just on imaging studies. And even if you consider EUS, I would only do it for analyzing, for looking at the intracystic appearance, because there are studies showing that MRI is not as great in looking at intracystic features. There's significant intra-observer variability among radiologists for the intracystic features, and hence EUS would be useful. That's in case if any of the cysts are approaching 2 centimeters. And since there is, if none of the cysts are more than 2 centimeters in size, that's my approach. But if, of course, if any of the cysts tend to grow, and then you do EUS, and if you have to do fine needle aspiration, of course, the goal is that if you do end up diagnosing cancer, then you would refer the patient to medical oncology for treatment. But again, if the 90-year-old patient is highly functional, in a very selective basis, surgery can be considered, only if you can diagnose a cyst with advanced neoplasia.
Sure. Another question came through. We heard about MRI, but is sonogram alone able to evaluate cyst morphology?
Trans-abdominal sonogram is inadequate. It's typical right upper quadrant ultrasound if that's what we're talking about, is not optimal for evaluation of pancreas, either cystic lesions or solid lesions.
Sure. In my experience also, I mean, they are at the best able to tell us about the location of the cyst and at the best the size of the cyst. Anything more than that, any morphological details are typically not possible with transabdominal ultrasound. And Dr. Krishna, in your experience, what percentage of these pancreatic cystic lesions are symptomatic when those symptoms can be actually referable to the cyst itself?
So in our single center study, which we published, we enrolled 144 patients. And of course, the study was looking at the diagnostic accuracy of endomicroscopy. In that, only 20% or less, if I remember right, had referred symptoms which were because of the cystic lesion. Of course, the enrollment criteria in our study was 2 centimeters in size. So there is that, and if you enroll all comers with pancreatic cystic lesions, the percentage of cystic lesions with symptomatic cystic lesions will be much lower than that.
And was there any relationship to size and location in the pancreas?
Yes, certainly. I mean, if you have a pancreatic cystic lesion in the head of the pancreas, which is compressing on the bile duct, the patient could present with jaundice. Of course, typically these cysts will have advanced neoplasia.
Sure.
And sometimes some patients come with a history of acute pancreatitis. The theory being that if it's an IPMN, it can release really thick mucin, which could temporarily block the main pancreatic duct and result in acute pancreatitis. So typically, and so also some of these IPMNs, which they're closer in the uncinate or the head of the pancreas, when they extrude the mucin, they can cause recurrent attacks of abdomen pain in some patients as well. So if a patient if a patient ends up having symptoms, more often than not, you will find a cyst with some advanced neoplasia, some degree of advanced neoplasia.
And when you see post-EUS procedure pancreatitis, how severe is this?
So again, quoting our single center study, the severity is mild based on the Atlanta 2012 classification. Generally, patients may require hospitalization for a day or 2 at max. As far as the severity of acute pancreatitis following through the needle biopsy, there is a recent prospective study from Europe where they had nearly 10% risk of, I believe it was a multi-center prospective study, and the risk of pancreatitis was about 10%. And in fact, there was one of the patients died because of post-EUS pancreatitis. So the theory is that I believe this is more in mucinous cysts and typically IPMNs, because the entry point of the needle through the cyst, there could be leakage of the cyst content. And since IPMNs communicate with the main duct, at the entry point of the needle, you could have leakage of enzyme-rich fluid, which probably causes peripancreatic inflammation and necrosis and pancreatitis. So it's kind of more of a theory, but that's probably the reason why if you use a larger bore needle, you have a higher risk of pancreatitis. And so also what we call is how long the needle, the stay time, meaning for how much duration of time was the needle through the cyst. And so also during endoscopic ultrasound, how much were you maneuvering the scope or the elevator? So in fact, if the needle has gone through the cyst, kind of grinding the needle around the cyst can increase that entry point and increase the risk of leakage of these fluids from the cyst. So these are all, again, theoretical concerns, but certainly data points towards a higher risk and probably more severity with through the needle biopsy forceps, more so, I would say, in IPMNs.
Sure. I have two questions regarding the NGS, which I'm going to try clubbing together. When are you using the genetic molecular markers on a regular basis? That's first question. And the second one is, somebody asked, can we avoid tumor marker staining in the biopsy specimen if NGS is being done in the aspirated fluid?
So now one key question with NGS is the cost. We have collaborated with our genomic pathology lab, and we have been able to subsidize the cost significantly. So we process the fluid specimen in-house. We avoid any kind of freezing and thawing. So we're able to ship the specimen. We are able to get the specimen to our lab and have the lab process for these genetic markers. So we have a much lower threshold to send it in case it's kind of part of a standard diagnostic workup sometimes, since we can use a 22 gauge needle. If you're going to get fluid for CEA, cytology, and glucose, we don't hesitate in adding NGS because of the low cost at our center. Now, this will not apply for all the centers. If you use commercial labs, the cost is expensive. Depends on insurance coverage. If the patient's insurance will cover it. As far as I think the second part of the question was obtaining a microbiopsy and staining that for using that for NGS. We have done that specifically for the classic microcystic serocystadenomas. You don't get free fluid when you aspirate, and we have obtained a microbiopsy from these microcystic lesions, trying to find VHL mutations.
So Dr. Krishna, another question came up was, is there any role for monitoring serum tumor markers like CA19-9 in patients with pancreatic cystic lesions?
So if you follow the updated 2017 guidelines, the international consensus guidelines, CA19-9 is a worrisome marker. If the cyst is, I would say if the cyst is more than 2 centimeters, it's advisable to obtain a CA19-9. And there is data from more studies from Asia showing that if there are IPMN lesions, these patients are at a higher risk to get pancreatic adenocarcinoma, not from the cystic lesion, but elsewhere in the pancreas. So if the patient is being followed, there is no set guideline as to how frequently you have to obtain the CA19-9. But say if you have patients with a family history of pancreatic cancer, IPMNs, and the size is slightly increasing on MRI surveillance, it might be advisable to repeat the CA19-9 at least once a year or once in 2 years. I don't think there is data on monitoring CA19-9 over time and corresponding changes in cyst pathology.
A listener referred to the second of the 3 cases you presented. They noted the CA was high in that case. I believe it was about 800 or so, if I remember correctly, but the cyst turned out to be a pseudocyst. The listener asks, if the CEA was, let's say, 70,000 or so, would that change the way you approach the cyst? Or would it give any additional information?
So there is good literature showing that the level of CEA doesn't indicate the degree of dysplasia or advanced neoplasia. So the CEA level, as long as it's elevated, you label it as a mucinous cyst, just based on the cutoff of 192. But the level of CEA doesn't change your decision in managing the lesion.
And a question regarding pseudocyst. Is there still a size criteria for pseudocyst when it needs intervention if the patient is asymptomatic?
So this is more about managing pseudocysts, which kind of is not applicable for this talk, where we're looking at diagnostic evaluation for pancreatic cystic lesions. But if the general rule of thumb for any pseudocyst is if they are asymptomatic don't touch it.
Sure. That's pretty much it. I got a comment that NGS in Asia is not very costly any longer. It costs about $150 or so. So this is just FYI for all of us. And any idea how much you have negotiated the price down to with your lab over there, just to get an estimate?
About $250 per patient.
Okay. All right. So if there are any more questions, please have them coming in and we will do our best to address them. Thank you so much to everyone who was able to join us for the presentation today. We hope you carried back home a few key points that you can apply to your practice. For those questions we could not address today, we will continue the conversation on our ACG GI circle. So please continue to send your questions and we will do our best to answer those. Thank you so much, Dr. Krishna. Thank you so much, American College of Gastroenterology, for providing us with this opportunity.
Thank you, Dr. Biotra. And again, thanks to the ACG for giving this opportunity, and also thank all the listeners as well.